difficulties. So good afternoon again. This is Robert Leam at Lurie Children's Hospital of Chicago and Northwestern. And I have the pleasure of moderating this webinar for the American Society of Pediatric Hematology Oncology entitled Management of Refractory Pain, Practical Issues and Challenges. So I have a few housekeeping items before we get started. Please note that all participants have been muted for the presentation this afternoon. I'd like to direct your attention to the chat room on your screen. Please use this chat room to ask any questions, which I will direct to the speaker at the end of our presentation. So you can also use this area to let me know about any AV issues or technical difficulties that you're having during the presentation. So our speaker today is Dr. Stefan Friedrichsdorf of Children's Hospitals and Clinics of Minnesota, where he's the medical director of pain and palliative care. Dr. Friedrichsdorf received his MD from the Medical University of Lübeck in Germany. He completed his pediatric residency at the West Children's Hospital in Detton in Germany and the University of Witten-Herdecke. He then went on to a fellowship in pediatric pain and palliative care at the Children's Hospital at Westmead in Sydney, Australia. So Dr. Friedrichsdorf, thank you again for presenting today.
Thank you so much, Robert, for this kind invitation and the invitation by ASPHO to present. So I'm very excited to talk about management of refractory pain and really talk about some practical issues and challenges. As for disclosure, I in the past have been a consultant for Vitu Pharma. However, everything I'm saying right now obviously are my own views. There's no conflict of interest. And I will use unapproved use of commercial products. Many medications we are using in the management of children with advanced pain are not FDA approved. Even oral morphine is not approved for the use in children. In terms of learning objectives, I think the three things we'd like to do today is really quickly look through courses and pathophysiology of children we commonly see with refractory pain, and especially with kids with blood disorders and with cancer. And look through strategies, how we evaluate and then treat children with this advanced pain. And really, an importance of this talk today is to combine active pharmacological with integrative and non-pharmacological approaches, and also look into new pharmacological agents such as dexmedetomidine, Precedex, low-dose ketamine, and how we use this in our daily treatment. So what is refractory pain? So when we see children with cancer or hematologic diseases such as sickle cell disease, we see children who basically remain in pain beyond the expected time of healing. And that pain just doesn't go away if we use standard treatment with opioids and co-analgesics. And most of the time, fortunately for us, when we say refractory, it means it's really difficult, but we can be mostly successful. However, rarely, sometimes, refractory really means refractory, meaning that despite all our efforts, we're not able to take this pain away, and this, especially in kids with advanced cancer towards the end of life, in very, very rare situations, then palliative sedation would come into our thinking. So if we go to a child and say, hey, what's your pain number between 0 and 10 now? We use some faces, and they tell us 7 out of 10. This is often not very helpful information, because what are we really measuring? Are we talking about active, nociceptive, somatic pain? So this is pain which is usually caused by tissue injury, by a bone is sticking out, something is burning, something, it's basically something where we know what we're treating, and this could be muscles, joints, tissue injury. It could be chronic somatic, so these are children who have the same pain on the same spot for a long time because the tumor may be pressing out for a long time, or it could be chronic arthritis. And then completely different, but also nociceptive pain, could be visceral pain, pain within the internal organs, pressure inside a liver capsule, for instance, or commonly seen bladder spasms. A completely different animal is, and we're going to talk about that as well today, is neuropathic pain. So resulting from injury or dysfunction of the central nervous system and peripheral nervous system. And then we have a large number of children who obviously, in addition to those pain, also have psychosocial, spiritual, and emotional pain, or something we call total pain. Something which is real pain, but will not be able, is not fixable with morphine or other medications. And then at the end today, we're going to talk about those complicated children who also have chronic pain. So pain basically stays beyond the expected time of healing. And we see the most complicated kids we see who have an underlying acute pain disorder and who also develop chronic pain. So how common is this? Pain obviously is fairly common in our daily management of inpatients with cancer, with malignant conditions, and hematologic conditions. We know from cancer, and again, you will get those handouts that will be posted by ASPHO on this website. So you will have all this information and also some slide with additional slide later on. So we do know that inpatient, up to 50% of children at any given moment do suffer from significant pain. And even cancer survivors have a much higher degree of developing chronic pain later on in their life. So what we often see, and these are the children who often we're dealing with when we talk about refractory pain, are children who have a chronic or acute pain. So they have an underlying disease, and on top of that, they develop chronic pain. A classical example might be in the hematology world, sickle cell pain, which we know is largely episodic in our young school-age children. And then it's increasingly frequent, in some cases persistent in preteens and adolescents, and frequently chronic in adults. And in the past, we basically, the treatment of those vaso-occlusive crises and this pain has largely relied on opioids. However, in the past, we really understood the underlying mechanism quite poorly. And but now there are more studies coming out which examining the role of peripheral and central sensitization. And we in fact may see opioid-induced hyperalgesia. So the pain medication we're giving, the morphine, the oxycodone, the hydromorphine, in fact may even cause pain in those children. So sickle cell pain is a classic example where the acute pain, the nociceptive pain, the mechanical vaso-occlusion as a sole explanation for pain does not hold true anymore. On top of that, we have significant issues with neuroplasticity. We have chronic inflammation. We have peripheral and central nervous system sensitization. And so we have more and more research coming out really showing that, in fact, a significant number of children with chronic sickle cell pain, in fact, have neuropathic pain. And we're going to talk about this more in a minute. And we do see more research regarding to heat and cold hypersensitivity in patients with sickle cell disease. So the questions which we then would want to ask is basically, does chronic sickle cell pain, meaning those children who seem to be beyond their acute vaso-occlusive crisis, but who tell us that they are in pain every single moment, every single day, 8 out of 10, 9 out of 10, 10 out of 10. So is this really just nociceptive pain? Or is this actually inflammatory pain? Could this be, or could it be that this veno-occlusive pain is just not as opioid responsive as we have thought in the past? Or is it more, we're going to talk about this at the end of this presentation today, is this really chronic post-surgical pain? So a transition from acute to chronic pain, and does this apply? How much of this is neuropathic pain? Because we do, there's more and more research coming out of this. Or is this daily sickle cell pain, in fact, it's really chronic musculoskeletal pain? And the answer probably is yes to all of the above. So it's multifactorial and it's complicated. So why bother? I mean, why do we even have this presentation? I mean, this little bit of pain, doesn't it just build character? And no, it doesn't actually. And we do know that children heal better if we provide good analgesia. We also know that children and teenagers with persistent pain, when they become adults, suffer much more physical symptoms such as anxiety and depression. And we do know if we do something stupid right now, if a child is coming to our institution, if we do painful procedures, if children are admitted and suffer from acute pain, and we don't take this away, that they actually will need more analgesia and more anesthesia at subsequent treatments and at subsequent procedures. So we have to be pretty good right at the very first time. We do know from our NICUs, from our neonatal intensive care units, that in fact there's an increased morbidity and an increased mortality of unrelieved pain in our babies. So taking pain away is really rather important. So how do we manage acute pain? As you recall from the beginning, the three topics I'd like to quickly cover today is acute nociceptive pain, that's part one, neuropathic pain will be part two, and the chronic unacute pain will be part three. So let's talk about acute pain, tissue injury. And really what we want to do is opioid-sparing analgesia. We really have learned that opioids are groovy. Don't get me wrong, morphine, fentanyl, oxycodone, this is good stuff. However, we've really learned that alone it's just not enough, and we have to use multimodal analgesia. So using the World Health Organization ladder, really step one is using acetaminophen, Tylenol, and non-steroidals. And not one non-steroidal is better than the other, meaning ibuprofen is not necessarily any better than diclofenac or naproxen or ketorolac, Toradol. They're pretty much equal analgesic. And however, we have the best safety profile for ibuprofen, so this is usually what we start with. If we have children who are thrombocytopenic, neutropenic, where an NSAID would have contraindications, in those situations, we here children in Minnesota use a lot of celecoxib, the only remaining COX-2 inhibitor, which seems to have a very good safety profile in terms of bleeding. So we wouldn't see this at any, and we wouldn't have increased bleeding risk. A probably much better safety profile for GI upset. We do not have a better safety profile for renal toxicity, and we do not have a better safety profile in terms of vascular events such as thrombolytic events, DVT, etc. So how do I feel pain? So if I have an injury in my foot or in any other body part, really what's happening is that my first neuron, a myelinated A delta fiber, sends up an action potential right into the spinal cord, into lamina 1 and 2 of my dorsal horn. And all that actually needs to cross over at the synapses into the second neuron, into the spinal thalamic tract. And the thalamus basic is nothing else than a relay station. It's a computer chip in our brain which perceives this action potential and then brings it to higher parts of our cortex, which will then decide in how much pain I will be in between 0 and 10. So non-steroidals such as ibuprofen, naproxen, or COX-2 inhibitors such as celecoxib work very much in the periphery, whereas acetaminophen, Tylenol, works centrally. So for analgesic purposes, they work completely different and might be combined. The second principle in order to use multimodal analgesia is to use opioids. And again, none is better than the other. Morphine is not any stronger than dilaudid hydromorphone or fentanyl, oxycodone, or methadone. They're equal analgesic. However, they're very different in terms of half-life, in terms of active metabolites. And what we find is there is no perfect opioid, meaning one child may have excellent pain control and morphine, and the next child only excellent on oxycodone, the third one on fentanyl. And that very much depends on the pharmacodynamics, on the pharmacokinetics of the opioid, but also our mu receptors, our mu opioid receptors, are very different in different individuals, and that explains why we often have to rotate. We have to switch from Coke to Pepsi. If Coke doesn't work, then we have to use Pepsi. If morphine doesn't work, we go to fentanyl or to oxycodone, hydromorphone, to find out what is the best opioid for this particular child. And there are 4 WHO, World Health Organization principles, and I'm just going to quickly review the two most important ones in a second. So opioids work centrally as well between the first and the second neuron and provide pretty awesome pain control for acute pain. We're going to talk about in a second that they're basically contraindicated for chronic pain, and it would not work particularly well. The 2 WHO principles I quickly want to review clearly is the PRN. And as you know, unfortunately, all data has shown us that PRN dosing as needed doses often means patient receives nothing. In 2 out of 3 cases within the United States, a PRN dose does not reach the patient. So if we know that the child is in severe acute pain, there's tissue injury, we are quite certain that we can treat this with an analgesic, then it would be state of the art to schedule analgesia. Could be something very simple such as give ibuprofen every 6 hours, or give paracetamol, acetaminophen, Tylenol every 6 hours, or give morphine every 4 hours, or give a continuous infusion of morphine, fentanyl, hydromorphine, and so on. Something around the clock. And then on top of that, we clearly would use extra doses, rescue doses, PRN doses, because the same patient with the same weight and the same sex and the same underlying disease in the next bed may need 5 times or 10 times as much of the exact same opioid as the patient next door, just because, as we just talked about, of different pharmacodynamics and pharmacokinetics. The other principle is now that parents often assume that good pain control means that we put their kids to sleep. In 2015, accent pain control means we can pretty much always, in more than 99% of the cases, promise accent pain control without oversedation. Clearly, children, if they have not slept for the last 48 hours because they were so uncomfortable and were in pain, have to pick up some sleep, and they may fall asleep right away after we're giving appropriate analgesia. But using multimodal analgesia, as we're just talking about, and not relying just on, say, a dilaudid PCA, which alone may not be effective, will actually we can pretty much promise nearly all the time really good pain control without oversedation. And again, when I say really good pain control, we cannot always promise a 0 out of 10. And that's far beyond this talk, but kids have different assessments, and in order to keep safety, to make sure that all kids are breathing, it might be necessary to tolerate a 0 or 1 or 2 or a 3 out of 10 for acute pain. For chronic pain, if kids have been in pain 8 out of 10 for the last 3 months, there is no medication to fix this anyhow. We're going to talk about this, how to manage this with a rehabilitative approach towards the end of this presentation today. Then the third principle and don't get me wrong, I love drugs. If I have open heart surgery, I want the really good stuff. I want the fentanyl, I want the dexmedetomidine, Precedex. We're going to talk about this. But what we have learned is that we must, as in have to, there's no other fabulous way, use active integrative modalities in addition to pharmacology. Medications alone in many of our children with refractory pain will not be enough. So we do have to use other modalities, and key are active mind-body strategies. It could be something physical, offering massage, comfort positioning, making sure that parents or caregivers can hold their child. In addition to that, it's extremely helpful to at least offer one active mind-body technique, such as bubble blowing, deep breathing, self-hypnosis, progressive muscle relaxation, autogenics. All of those might be particularly helpful. And we often see that in our most complicated teenagers that they might be less inclined to do something active, but like the passive stuff, they do like massage, they do like acupuncture, acupressure, but the passive stuff alone is often not enough, and we strongly expect from our kids that they at least practice one active mind-body technique if they're old enough and don't have any cognitive impairment to do that. If right at this moment there's nobody in the team who is able to teach any of those modalities, I'm thinking child life, I'm thinking integrative medicine, but any clinician usually has at least one thing, and bubble blowing is quite simple. We can use, there are lots of apps we can just download on our smartphones or on tablets, including the one we've developed here at Children's, which is called Healing Bodies Comfort Kit, which is available for free, and has lots of modalities for pain, nausea, and vomiting in there, and you're free to try this out and see whether you like that. So why is this distraction? Why is the hypnosis? Why are those apps? Why is playing a video game extremely helpful in decreasing pain? Well, the bottom line is, if you're listening to a really boring presentation and you have a little bit of a headache and your pager's going on, your headache actually may get much worse. However, if you're sitting on the beach right now with your favorite drink in your hand, you're looking into the sunset while feeling the sand under your feet and the dolphins are kissing each other, you may not even notice that you have a headache. So what you've just experienced is basically a release of endorphins in your periaqueductal gray. And by doing this, we can actually stimulate descending inhibition. So you're providing distraction, providing mind-body techniques, integrative non-pharmacologic modalities. In part, we are actually able to reduce the amount of action potential reaching the thalamus. This explains why many of our kids and teenagers do better throughout the day and fall apart at night when there's much less distraction around. And for many of our difficult kids, if the simple non-opioids with opioids and using integrative therapies is not enough, then we must offer rehabilitation. Exercise, getting them out of bed, having a routine, making sure that they're sleeping at night and up throughout the day is absolutely key. And if we have children with anxiety, with depression, who are missing school, then we need to offer basically the best evidence treatment, which is cognitive behavioral treatment, CBT. And occasionally we run into difficult families or patients who really only exclusively want to utilize medications to manage their pain and may not be interested in integrative therapies or in exercise or in sleep hygiene or in psychology. And I often very honestly tell them, I'm not sure I can help you. I do not believe that a medication alone is going to fix all those pain issues. If you're not interested in practicing something active, if you're not interested in seeing my pain psychologist, if you're not interested to get out of bed and do some exercise, I'm not sure I'm able to help you. And but I will check in with you every day, and you let me know when you're ready to do this. And these are, of course, difficult discussions. State-of-the-art multimodal analgesia means that we obviously have to make sure that pediatric anesthesiologists who are trained in invasive approaches, such as regional anesthesia or neuroaxial anesthesia, are part of the team. If I have pain in my foot and I can block the pain excitation, the action potential reaching my dorsal horn, then I may not need opioids. I may not need lots of medications. So it's absolutely paramount that pediatric anesthesiologists who are trained in this are part and weigh in whether or not this will be helpful for the children we're talking about. And especially for children with visceral pain as well as for neuropathic pain, a key component, in addition to everything else, not in stat, are adjuvants, such as Gallopington, such as Amitriptyline, such as alpha agonists like clonidine or dexmedetomidine, low-dose ketamine or other NMDA antagonists such as methadone, lidocaine. So there's cool stuff, and we're going to talk about this quickly in a moment. So the bottom line is multimodal is awesome. This is really what we need to do. But we need to remember that the multimodal analgesia has a lot of non-medicine components and that we cannot promise excellent pain control with a hydromorphone dilaudid PCA only. This alone will fail in most of our patients. And we do know that multimodal analgesia reduces the length of hospitalization in many of our patients. So let me introduce you to a real patient of mine, a patient I saw a few years ago. Let's call him Clark, which is not his real name. It was a 15-year-old with relapsed T-cell lymphoma. And he basically had second-line chemotherapy and developed out of this world neuropathic bilateral foot pain 9 out of 10. He also had some hemorrhagic cystitis, some abdominal pain. And when we received the consult, the oncology team appropriately had started him on a morphine PCA, continuous infusion plus bolus, switched him over due to side effects to fentanyl, and then switched him over to hydromorphone, continuous infusion and boluses. The thing was, the stuff was not really working all that great. And he was just pushing that button 50, 60, 70 times a day. So he was either totally zonked out and unresponsive, or he was in pain 9 out of 10. So this is a typical example of development of neuropathic pain. We don't know how common this is. We know from our cancer population that somewhere between round about 20 to 40% of children do develop neuropathic pain during that treatment. So it's something fairly common. And since neuropathic pain is less responsive to opioids. It also speaks and is probably one of the main components of the children with sickle cell disease, with phantom limb pain. It may explain why those are so much more difficult to treat. So children with neuropathic pain, where we have damage of the CNS or peripheral nervous system, this could be just caused by a tumor. So it could be a direct tissue or nerve injury. A large number of children, teenagers, and adults after amputation do develop phantom limb pain. So key here is to really implement those strategies prior to the surgery, showing that, and we're going to talk about using adjuvants such as Gallopington, Amitriptyline, dexmedetomidine, clonidine prior to the surgery to basically calm down the nerves so that we have a lower risk of phantom limb pain afterwards. And of course, commonly seen, the chemotherapy is causing neuropathic pain, specifically vincristine and cisplatin, but obviously there are many more agents who can cause that. And we see children with spinal cord injury, which may result in neuropathic pain. So in your handouts, you have a fabulous 2015 presentation from Finnerup, who again reviewed adult data for neuropathic pain, and it looks into the numbers needed to treat. How many adult patients do we have to give this to make one better by 50%? And you see that many of the adjuvant analgesias we use, like amitriptyline 3.6, it actually only helps 1 out of 3 to 4 patients. And again, this is adult data. We do not know how well this is working in children who have different underlying conditions. Gabapentin 6, pregabalin, Lyrica like 8. So this stuff is only an adjuvant, is an add-on, and we have to often combine different adjuvants to hedge our bets a little bit better. So when I treat difficult patients with neuropathic pain, such as Clark, of course we always go back to square one, which means we identify and treat the underlying disease process. Could radiation, could corticosteroids be something which would be helpful here? In Clark's case, it really was chemotherapy induced. So, and the oncologist by that stage had stopped giving this particular chemotherapy agent. The second step is offering integrative therapy. So when I introduced myself, I love drugs, as you can imagine, but I'm also trained in self-hypnosis. So I offered him to teach him hypnosis, which he quite liked. And he, in fact, wanted to play video games at home. So we used this video game as a picture to distract himself. I also asked our physical therapist to look into exercise. And first, we need to get him better. Right now, his pain was so bad, and he wouldn't get out of bed. He couldn't even put a blanket on his foot. But starting day 2, he actually was willing to do some exercise. And I'll tell you a little bit how we got there. And he clearly was anxious, had some anger, and basically I told him that I have a very groovy pain psychologist, and would it be okay if Dr. Gibbon would swing by and do some more hypnosis and talk to him? And he fortunately agreed to that. Not all patients would, but he did. And so Dr. Gibbon, then my pain psychologist, he and the team started to take over. And we had to get his sleep upright. He was up a lot at night. He slept through the day. So sleep hygiene was clearly quite important. Number 3 is I asked a pediatric anesthesiologist colleague and see whether regional anesthesia would be appropriate. And he felt that indeed a tunneled catheter and an epidural might be appropriate. However, Clark at that stage was not very interested because he wanted to walk, and when he heard that he may not be able to walk with his epidural, then since he wanted to go home, he passed on that for now. For new onset neuropathic pain, such in Clark's case, opioids actually work. Not for everyone, but sort of half the time. So he already had been on morphine, he had been on fentanyl, he had been on hydromorphone dilaudid, so opioid rotation makes sense. In this case, I would switch to methadone. However, he was so oversedated, he was so sleepy that I couldn't switch him to something like methadone, which has a very long half-life, and it's difficult to assess whether or not I'm oversedating him now. So he had to be better first. So it took me actually 2 days, me and my team, to switch him over from hydromorphone to methadone. And clearly there's good data showing that non-steroidals, ibuprofen, or if there are contraindications, a COX-2 inhibitor such as celecoxib, in fact provide additional bang for the buck in terms of even for neuropathic pain. The next thing I started with Clark, and I do with many patients, is a whiff of a splash, a low-dose tricyclic antidepressant. I usually start with Amitriptyline. However, other big centers in the country would start with Nortriptyline. Again, this is Coke or Pepsi. Amitriptyline has slightly higher anticholinergic side effects, so I have a higher risk of constipation, hallucinations, or urinary retention. On the other hand, I have a higher chance of getting them to sleep tonight. And since many of those kids and teenagers don't sleep well, I do run an EKG to make sure that they don't have QTC prolongation, unless it's advanced end-of-life care, where I do not want to know the results, then I may not do this test. If pain is absolutely out of control, as it was here in Clark's case, then I would start a very low-dose ketamine. Low-dose ketamine, we're talking 1 to 5 micrograms per kilogram a minute. So that's somewhere between 60 and 300 micrograms per kilogram an hour. So that's a whiff of a splash. Usually doesn't produce side effects we would see from high-dose ketamine, but provides significant, by closing NMDA channels, provides significant additional analgesia. So we use this quite a bit in children where we have gone from 1, 2, 3, and 4, and basically find that we can't really wait for the amitriptyline or gabapentin to kick in, because it may take several days before we see an effect here. And with low-dose ketamine, we usually see the result within an hour or two, so that is very helpful. In Clark's case, low-dose ketamine really decreased his pain significantly, and he was actually able to start then exercise and physical therapy, which then helped further. The next step is to basically combine amitriptyline with gabapentin. Again, as you've very quickly seen a few slides ago, we now know that gabapentin, at least in adults, is more efficacious than Lyrica pregabalin. So that's another good reason to start with gabapentin. However, if Coke doesn't work, again, we can switch to Pepsi in this case. If gabapentin doesn't work, we would switch to pregabalin Lyrica. Clark had side effects with gabapentin in the past, which were unclear. So actually, and he wasn't interested in starting it. So I actually started him on pregabalin and slowly increased him to the maximum dose of 300 milligrams twice a day. Something Clark liked a lot, and many of my patients like a lot, is the lidocaine patch. So if they have localized pain, cutting the patch, putting on the spot is quite helpful. How much of this is a self-fulfilling prophecy, a placebo effect, and how much of this is actually based on science is unclear. However, many of my patients tell me that they like it a lot. And in fact, after everything was said and done, the single medications Clark told me helped best, he felt, was the lidocaine patch. I'm not sure I would see it the same way, but this was his perception. If that doesn't work, then we come to the real cool stuff. So low-dose ketamine we already talked about. I'm a big fan of alpha agonists. So dexmedetomidine, Precedex, is something we use quite a bit as an intravenous infusion. We usually don't use it for boluses anymore, definitely not in our infants. Where we do use Precedex, we can switch it over to clonidine, either as a patch or as an oral dose. In some children, especially with neuropathic pain, intravenous lidocaine might be quite helpful. There's some data that for localized regional neuropathic pain, botulinum toxin A could be helpful. A very low dose, a whiff of a splash of a benzodiazepine, may be a nice adjuvant for advanced pain. An SNRI such as duloxetine or the capsaicin, which is substance P inhibitor, which is basically red hot chili pepper as a patch for localized neuropathic pain, might be helpful. I've never used the capsaicin, however, there's some good adult data. But you do have to numb the skin because it might be quite painful. So Clark got much better, and he was able to go home on 10 milligrams of methadone 3 times a day. For rescue dose PRN, I prescribed him some hydromorphone. He was on the pregabalin, as I've mentioned. We usually, there's good data showing that the amitriptyline or nortriptyline is not dose dependent, meaning we usually do not see an additional effect beyond 20 or 25 milligrams once at night for either of those medications, so I usually don't go higher than this. We switched the intravenous continuous infusion of ketamine to oral ketamine. It tastes awful, so we have to mix the IV stuff into some flavors which the kids or the teenagers like. And he took it as needed and stopped it after about 2 weeks. And he loved his lidocaine patches, which he put in both feet and felt they were absolutely fabulous. And he only stopped them after about 3 weeks. So Clark went home, and we provided palliative home care with our team here at Children's in Minnesota, in Minneapolis and St. Paul, and he died peacefully about 8 weeks after after we were able to send him home. So I would like to spend the last 5 minutes of my, or 7 minutes of my presentation today on chronic pain, because a large number of the children we are seeing with refractory pain, we've used all the medications up. Really what we're seeing, it might be chronic pain. So chronic pain means that the pain extends beyond the expected time of healing. So the pain is not a warning sign anymore. In other words, the kids we see with chronic sickle cell pain who tell us that they have back pain 10 out of 10, even long after the last vaso-occlusive crisis, that pain has lost the warning sign, yet the pain is real. Of course, the kids are not making this up. In the general population, children who do not have an underlying malignancy, an underlying hematologic disorder, chronic pain is common. So depending on the surveys, around about 15 to 20 to 25% of any child, of any teenagers in any school has chronic pain. However, only a small amount of them fall through the cracks who really seem to have trouble and you need an intensive pain rehabilitation. So the majority of those kids have pain, but they go on with their life and they're not disabled by them. We recently did a survey among all our inpatients, and we found that on that particular day, in fact, 12% of the kids who were hospitalized on that day did have clinical signs of chronic pain, lasting more than a month before they were admitted. A common theme we see in many, but not all, but in many of our kids with very difficult to treat pain is who have chronic or acute pain is a sense of catastrophizing. This might be true for the patient. This might be specifically true for the parents. The research is showing that it's more common in mothers than in fathers, but it certainly happens in all caregivers. And this catastrophizing, this awfulizing, nothing is going to get better, nothing is going to work, really is a self-fulfilling prophecy that worsens our chances of managing this. And the thing is, of course, that obviously kids have fear of pain. Pain is usually a warning signal. If I put my hand on a hot stove, obviously the pain tells me, well, do not put your hand on a hot stove. If they're moving and the back pain gets worse, they say, well, that's a warning signal, I shouldn't move. And they may not appreciate, unless we tell them, that in fact first their function goes back to normal and then the pain gets better. And sometimes the pain may even get worse before it gets better when they're doing so. So what we have learned over the years is really if the most common chronic pain in children and teenagers in this country are headaches, migraines, fibromyalgia, joint pain, back pain, functional abdominal pain, that this is really not thought a different separate disorders anymore. In fact, what we see is just a symptom, a manifestation of the same underlying vulnerability. In other words, we have lots of evidence now that if kids develop one of those pain disorders, this is more a pain vulnerability, a pain sensitivity as such. In other words, in those kids who only have chronic pain or have chronic on acute pain, it's like this big iceberg floating in the water, and they just develop like one symptom. They develop the joint pain, or the wandering pain in the leg, or the fibromyalgia, or the headache, or the migraine, or the functional abdominal pain. But what we're treating is really more the underlying vulnerability, the sensitivity, and much of this is underwater. We can't see that. So conservatively, at least 5% of children and teenagers in the general population in Western countries have significant pain, pain bad enough that they miss school. So that means at least 5% of the children who have bad disease, who have cancer, who have hematologic diseases, at least 5% have also chronic pain on top of the acute pain. That pain is real, but it may not have anything to do with the cancer or the sickle cell disease. In fact, probably everything is connected to everything. Having the same pain on the same spot for a long time leads to a much higher percentage of children and teenagers and young adults who develop chronic pain. If I have a fracture of my right wrist over and over again, the more often it happens, the more likely it is that I develop chronic wrist pain. And the same is true for kids who have recurrent cancer, who have sickle cell disease or other underlying conditions. So when we want to help those kids who in the past may thought all I need is a dilaudid hydromorphine PCA, and we know the stuff is not working. It's really not the stuff. What we often do is we tell the pain is real. You're not crazy. You're not making this up. But with this chronic pain, which comes on top of the acute pain, first the function gets better, then the pain gets better, and not the other way around. They cannot lie in bed and wait until the pain gets better and then start walking around. That's hard. So what are the 4 non-negotiables? What do we need to successfully get rid of chronic pain on top of an acute pain? Number 1 is clearly physical therapy. Kids need to get out of bed, and it could be anything if they have from weight bearing for 1 second to running a marathon tomorrow. In other words, it just means it depends on the individual child what exercise they can do. We start very slowly and then get better. As I've mentioned earlier, we would expect to use active integrative modalities, teaching self-hypnosis, biofeedback, using an app. And I would expect that those patients are practicing this every day. And again, they're very different modalities. And and some kids, they might like this, some might that, and some it may not be culturally appropriate to use this or that. So it depends, but we would offer whatever's best for this particular child. And as I've hinted earlier, if children are missing school, if we see anxiety, depression, it is in our program non-negotiable that they need to see a psychologist. And if they're not willing to do this, we will say, okay, I appreciate this. Tell me when you're ready. Yeah, I will not be able to get your pain down to 0 or 1 or 2 just with opioids. It just is not going to work. And I will not prescribe this stuff if I don't feel that this is helping. Because pain often causes more stress. But if people have more stress, then they have more pain. If they have pain, they have more stress, and then they have more anxiety. And if they have more anxiety, they have more pain and get more grumpy. So everything is connected to everything. So we talk to our kids and teenagers and young adults and tell that we have to decrease stress. We have to decrease anxiety. We have to improve grumpiness in order to decrease pain. And this is what a pain psychologist, a pain therapist is for. And lastly, it's clearly important. First, life gets back to normal, and then pain gets better, and not the other way around. And that means getting back to normal sports, or at least exercise, improving the sleep hygiene, and go back into somewhat of a social life, depending on the underlying condition of the child. And we really are very strong in getting them back to school. Unless the kids are homeschooled for religious reasons or siblings as well, we strongly emphasize full-time school attendance. And it could be a slow school reentry plan, or we would do a contract. On some kids, just go back to school tomorrow after they have learned that the pain is not a warning sign anymore. And we tell them that going back to school may increase stress, and that may increase pain. But sometimes pain may go up before it goes down. We do some family coaching. We talk to the parents so that they know what would be helpful in terms of expectation and limitations of a child in chronic pain. So what about medications for chronic pain? Well, there are not really good medications for chronic pain. I may use Amitriptyline as I would for neuropathic pain. We may use Gallopington for a few days. We may use acetaminophen. We may, for short while, use ibuprofen or celecoxib if there's an inflammation going on. Lidocaine patches. Melatonin may help for sleep. In higher doses, there's some data that it actually could be an analgesic as well. I'm a bit underwhelmed by vitamin D. I would treat it if it's low, but it's more a marker of chronic disease rather than the cause. We may, if kids are getting cognitive behavioral therapy, we may add an SSRI if significant anxiety, depression. So the bottom line is that opioids are contraindicated. If we do not know what we're treating, if there's no tissue injury, if there's no inflammation, we will stop the opioids. We will wean them down to make sure they're not withdrawing. And that often is difficult in some of our kids with long-standing pain. So I'm coming to the end of my presentation. The conclusion is that if children have acute pain, tissue injury, nociceptive pain, that we have to use multimodal opioid-sparing analgesia. An opioid alone, an adjuvant alone often is not enough anymore. We have to use the WHO principles. We have to tell our parents that they do not have to choose between poor pain control or sedation. And we shouldn't really, outside end-of-life cancer pain, opioids should not be administered long-term. We know from adults, if we write a prescription for opioids for more than 30 days, that half of the adults are still going to be on this opioids 3 years from now. 3 years from now, they will be still on the opioids if we prescribe for more than 30 days. And for many of our painful conditions, children really shouldn't be on opioids longer than 30 days, with certain exclusions, of course. On acute pain, kids who develop chronic pain on top of their cancer, on top of their sickle cell disease, on top of their phantom limb pain, and so on, we now have learned that really this is not peripheral nociceptive input, so it's not damage or inflammation. So it's the giving an opioid clearly does not work. We talked about that those kids really now that have to consider a manifestation of an underlying vulnerability. So we closely have to work as a pain specialist, as a palliative care specialist, with the oncologist, with the hematologist, to make sure that these patients get the best care. And again, opioids, in the absence of tissue injury or inflammation, are contraindicated. We do wean them down, and we do get them off, even if the patients don't like it. And key for chronic and acute pain is a rehabilitative, interdisciplinary team approach. With that, I would like to thank my amazing team here in Minneapolis and St. Paul, who are currently all seeing patients and doing stuff while I'm giving this little talk. And I would like to thank you very much for your attention.
So thank you very much for your talk, Stefan. We have a few minutes for some questions. I want to just remind all the participants to use the chat room to raise your questions or to make comments. And if we don't get to your questions today, we will post the questions with responses from Stefan on the website. Stefan, the first question from one of the participants, I think you've already somewhat addressed it towards the end, but maybe you could sort of reiterate. He'd like to know to what extent depression and or anxiety contributes to pain symptoms in adolescents with sickle cell disease and chronic pain. His impression is that, more than the neuropathic pain, these pain symptoms are kind of closer to psychogenic in origin and won't improve without aggressive treatment to the underlying psychological dysfunction.
I think I would agree. What we often find is everything is connected to everything. So five out of 100 children do have chronic pain, so we would think that 5 out of 100 kids with sickle cell disease will have some sort of chronic pain. And then if we look closer, who are those 5? Then there are risk factors, and one risk factor clearly is anxiety and is depression. But as is catastrophizing, as is poor parenting. Parents who keep their kids out of school are much more likely to have kids with chronic pain than those who do send them to school. So I think it's a little bit like quantum physics, meaning there are many, the sum is probably much more important than the individual parts. But I agree that, without addressing anxiety and depression, and an SSRI is often not enough. It actually means, like talking to someone who's restrained in this, we may not be able to promise excellent pain control.
Yeah, so Stefan, just as a follow-up to that, can you just comment on the identification of chronic pain? So it seems like patients at some centers are identified only after the chronic pain has been present for a prolonged duration or after the chronic pain exacerbation leads to frequent utilization of acute care services. Are we doing a pretty good job or not so good job of identifying early on who's going to develop chronic pain?
I think since we don't have any validated tools, we may have trouble to identify early on those chronic pain kids, because those kids have something real going on, right? I mean, they do have cancer. They do have a tumor. They may have a relapsed disease. They may have recurrent episodes of vaso-occlusive crisis, one of the most painful things a kid or teenager can go on. And then for some of those, the pain goes away for some of them, but for a small number, the pain just remains. So I think the classical adult definition of if you have pain for more than 3 months, you have chronic pain, probably doesn't work that well in children or teenagers. So the way we see it, and I think most of my pain colleagues would see it, is if pain remains beyond the expected time of healing. The pain is real, the healing has happened, and they're still in pain. Then I would see this as chronic pain. Yes, the pain is real. Yes, you have 10 out of 10 back pain, but no, this is not sickle cell pain, and opioids are contraindicated. We're going to wean you down in the next few days and start the really cool stuff, which we know is helping.
So another question from one of the participants is, can you comment on how long you wait until you escalate in your step-up pain management approach?
Do you think this is about opioids or like all the steps?
I bet it's probably a combination of the opioids and escalating to, to the multimodality approach.
Yeah. So I think it depends whether I'm treating acute pain or neuropathic pain. If it's acute pain, so this is a child coming in developing severe mucositis, right? This is bad pain. And I should be able to fix this, right? This is something which new onset mucositis due to chemotherapy, we probably should be able to get this under really good control in a very short time. So I expect, I would start an opioid, and if he or she doesn't develop side effects such as oversedation or itching, I would probably titrate this up. I would start a PCA, continuous infusion, and then I would give a bolus every 5 to 10 minutes until he or she tells me, okay, this stuff is working, and then I'm nowhere then. So I would be very quick in escalating this. If it's sort of new onset acute pain, I would expect to work. If it's more sort of long-standing neuropathic pain, visceral pain, I want to make sure that this is safe. And technically, I have to wait 5 half-lives of any opioid to sort of before I know to have a steady state. So morphine, hydromorphone, oxycodone have like a half-life of 2 to 3 hours. So it takes about 10 to 15 hours before I know where I am. So I probably usually wait 4 to 6 hours at least before I increase by usually 50%. If I'm giving an opioid, it should work, but it doesn't, and they're still breathing, I go up by 50% roughly every 6 hours if it's safe and if it makes sense in this particular patient. For the other modalities, it often depends. As in Clark's case, he was so oversedated, so I was very quick in starting the low-dose ketamine. In other kids, I may use other steps. I may have, in many patients, I would first titrate up the Gallopington and the Amitriptyline, and if that's not working, then I may add the ketamine. Is that a vague enough answer?
Yes. Right now I don't see any other questions, but I actually have a question for you, Stefan. Is just to go back to your comment about never really using opioids in chronic management of pain. What do you do for patients who do tell you that, or you have pain specialists who do think that sometimes chronic opioids, as long as you're functional, you're able to go back to school, go back to your job, that if you're able to do those things, then that it is okay to continue on chronic daily opioids. And I guess what sort of strategies do you use to talk to a patient to convince him or her to come off of those chronic opioids? Do you have any comments about that?
So it's a difficult topic, right? There are many pain clinics out there, or people who claim to be pain specialists, and the old thinking was, well, it's just a question of giving you opiates, it's going to work away. And now we have, especially in the wake of OxyContin, but extended release oxycodone, but other opioids, a large number of adults who basically have been on opiates for years, and it's not really working. So there's overwhelming evidence that long-term administration of opioids is not advantageous. One study is basically that chronic back pain in adults taking for years, there's no correlation with dose. Higher doses has no better pain control. So now that we know this, it's difficult because many of those patients may have brought up because they have had repeated episodes of Crohn's disease, of sickle cell disease, of other conditions, juvenile rheumatoid arthritis, and they feel, well, that's the only stuff which is sort of working, and many insurance companies are not willing to pay for physical therapy or psychology, although this is 10 times more effective than an opioid, and so it takes time. It really the communication stuff. Your pain is real. I'm worried about many side effects. I'm worried about opioid-induced side effects, and I basically said, if you'd like to follow up with me, I will help you to get off and make sure that you're not going to withdraw. I will probably switch you over to like methadone for a while, but we will get you off if there's no acute thing is going on, and so that sort of is part of the contract, the treatment. But it takes a long time to convince them, and sometimes for strategic reasons, I have then, rather than getting them off opioids in a month, what I would usually do, I may then choose to do it 3 or 4 months just because they have been on it for years, and that sort of is their thinking. Does that answer your question at all?
Yes, it does. Thank you. So I don't see any other questions, but so if we don't have any other questions, I think we'll go ahead and conclude our webinar. Stefan, I want to thank you again for helping us out and giving this talk, and I want to thank all the participants who participated in this webinar. Thank you very much.
Thank you.